Papa,
Prof,
how are you?
good. How are you?
Good, good.
How is TZ?
Tuesday is good, and today the place where I live, we got raining, so it's raining and yeah, and very hot in the morning, but it's fine.
It's raining. You guys are
Mm.
blessed.
Yeah, in your place it is too dry.
If it's raining, then that's great.
Okay.
Hi,
Hi, Maria.
Mariam.
Hi all. Have we opened up the webinar already?
Sorry?
Our presenters, they're not yet in.
Okay, Ingajima, I think you might have opened up the webinar, but that's okay.
Yeah, so but I think you can take it now.
Yeah, I think so. We just have some attendees here.
Okay.
No
I'm in
worries.
registered.
203 as of this morning.
Oh,
Yeah.
Kaka.
mm. So Mariam,
Yes,
No,
now you take it.
no.
I think I did.
Okay, cool.
SPK.
Yeah, Papa.
You're on the seatbelt.
Yes.
Wonderful.
Yes, we are on the seatbelt. Yeah, good to have you.
Good. The presenters well. Eat all the quells.
I've just contacted them. They're joining.
some music on that.
Hi, everyone. Good afternoon, good evening, good morning to all of you who have joined. I just wanted to take a few minutes to welcome you to this webinar and also thank you for your attendance. My name is Mariam Khan. I lead communications for Gradient Health Systems. Today, we will be discussing anesthesia-related mortality, as you see on the screen here. Before turning it over to our moderator, I just wanted to go through a few housekeeping announcements. If you have any questions during the webinar, please use the Q&A feature to ask those questions during the session. We will have Q&A at the end of the discussion as well. As you see, the webinar is being recorded. You'll receive a copy of the webinar following the end of the webinar, but if you don't for some reason, you can find the recording on our website, on our training page, or also on our YouTube page as well. And as always, if you have any feedback or want to see any topics covered, or have any questions for us, please email us at customers@gradienthealth.org. I'll now turn it over to our moderator for today's session, Dr. Papicho, to run us through today and also introduce our panelists.
Thank you very much, Mariam. Thank you to all our participants for being there today as we resume again with our clinical webinar. Today we are discussing anesthesia-related mortality. To discuss this, we will have two great presenters, Dr. Atala Abdallah and Dr. Amrina Samuel. They are all anesthesiologists practicing in Tanzania. Anesthesia-related mortality, it's something that nobody would wish to happen to him whilst giving anesthesia or whilst giving what we all enjoy. For sure, this is a real concern in low, middle income countries where standards and protocols are not always followed. So in today's discussion, we'll try bring up different ways to prevent such situation from occurring. So during this discussion, we'll talk about the epidemiology of anesthesia-related mortality, what could be the cause risk factors. We're also going to discuss the Swiss cheese model. Will be explained what is the Swiss cheese model, the role of the non-technical skills in the prevention of critical incidences, and then we'll have some incidence reporting models. What is the ideal model to use when unfortunately such a thing happened? Without taking long on the floor, I'll call upon our first presenter, Dr. Atala Abdallah, to take us through the discussion. You're welcome, Doc.
Okay, thank you, Papicho. As I've been introduced, I'm Dr. Atala Abdallah from Tanzania, and I'll take you through the first part of this webinar. Next. Yeah, so to start with, as the topic of the webinar, anesthesia-related death is one of the most dreaded and also fearful perioperative outcomes and a profound difficult experience for any anesthesia provider. And while these anesthesia-related deaths are becoming less common worldwide due to advancement in medical technology and practice, leading to decline of these deaths, they remain a significant concern, especially in the rural resourceful settings. So in most cases, these anesthesia-related deaths are usually preventable and avoidable due to several reasons, as we're going to see through our presentation. Next, please. Yeah, so to start, again, we're going to at least see the definitions when we say anesthesia-related deaths. So anesthesia-related death or anesthesia-attributable death refers to a fatal outcome that are directly attributed to the administration of anesthesia during a procedure. And when we say anesthesia-associated mortality, refers to a mortality occurring in the context of an operation performed under anesthesia. So whether directly or not directly involved with anesthesia. So they usually difficult to have an association or a cause association between anesthesia factors and the patient deaths. And also it is very difficult, as we know, to measure the anesthesia-associated mortality and evaluating the role of anesthesia as a part or as in this outcome. And when we say intraoperative death, which we sometimes refer to as death on the table or DOT, this describes the death of a patient in the operating theater during anesthesia or surgery. So this slide is just to for us to get familiar with these topics or these sessions as we get along the presentation. Next. So this is, as we say, we are going to talk on the epidemiology. So this one is a study done to assess the incidence of anesthesia-related deaths over 5 years from 2017 to 2021, as we can see. And the indicator was for anesthesia deaths, one for over 100,000 population. So as we can see from the total patients, there was a decline in mortality or in anesthesia deaths from 10.9, as you can see, from 2017 to 2021, that is 4.6. And also, as we can see, from ASA 1 to ASA 2, there was maybe not a much decline, but from ASA 3 and above in patients with general anesthesia, we can see there was a decline in anesthesia deaths incidents. So this is just help us to understand as we mentioned, there is a decline of anesthesia deaths related, and also what has been done, we are going to see later. Next. So this is also another graph that was a research done to assess the anesthesia-related deaths per 1 million population, and mostly shows the annual rate of deaths across various ages for almost 6 years. As we can see from age of 0 to 14, there is not much anesthesia-related deaths as compared to age from 15 to 64. There is a bit increase in anesthesia-related deaths, but there is more pronounced or marked increase in older population above 65 and above. So this just tells us the deaths could be due to the complex procedures that are elderly undergoing, and also the physiological changes that we all know, the reduced drug metabolism and the comorbidities associated. But the most importantly, this graph tells us as an epidemiology is just for us to understand the epidemiological age group according to the deaths of anesthesia-related deaths, and also for us as healthcare professionals to link towards improving safety protocols, enhancing training and vigilance, particularly over this age, as we can see from more on the elderly than the young adults and pediatrics. Next. So there are various factors that have been discussed that have attributed to the reduction in these anesthesia-related deaths. And one is advancement in monitoring equipment and the use of safer drugs. As we know, there is development and use of anesthetic drugs that have fewer side effects to improve safety profiles and reduce risk. The advancement in anesthetic machines, with the ones with controlled delivering of anesthesia and also minimizing errors, the advancement in airway management, the use of the fiber optic laryngoscope, the video laryngoscope, improving anesthetic and surgical skills and knowledge due to ongoing education, training of healthcare professionals to increasing competence and also skills, and most importantly, the availability of better guidelines and protocols that are up-to-date and evidence-based practice that have led to reduction over the years in this anesthesia-related deaths. Next. So there are several factors and causes that have been thought to be the cause of anesthesia-related deaths to our patients. So the first one is the circulatory failure due to hypovolemia in combination with overdosage of anesthetic agents. So excessive administration of drugs such as thiopental, opioids, benzodiazepines, or regional anesthesia, as we all know, their side effects are the depression in the cardiovascular system and also respiratory system. So the overdose of this may lead to anesthesia-related deaths. And the second one is the hypoxia and hypoventilation. So after, for instance, undetected esophageal intubation, the difficult intubations, or technical failure in anesthetic equipment, or aspiration of gastric contents. Other cause could be the anaphylactoid reactions, including the malignant hyperthermia, which we know will result in a rapid increase in body temperature and severe muscle contractions due to common drugs that we use, such as inhalational agents and some muscle relaxants. The last, but most important, that we are also going to have a discussion on it, are the human negligence, such as the lack of vigilance and errors in the administration of drugs. As we have for us in Tanzania, there are a lot of cases that there is error for administration of drugs, tranexamic acid being confused for bupivacaine, and in also errors in maintenance and control of anesthetic equipment. Next. Yes, so there are potential causes of adverse events in anesthesia, and there are several, but here we have categorized them into 3 factors. So the most important, the human factors, their patient factor, and also the system factors. So in the human factors, there's lack of vigilance, more on failure to monitor patients closely during anesthesia, which lead to a provider missing critical signs that require intervention, the poor teamwork or communication. We are going to discuss on the non-technical skills, the lack of knowledge on the clinical, the lack of clinical knowledge and insufficient understanding on the medical conditions of a patient, as well as anesthetic techniques that are used, and also the poor technical skills. Without forgetting the patient factors that are sometimes unavoidable, the comorbidities, emergency conditions, difficulty airway, and also the system factors. As we know, the low resources countries, so lack of equipment and essential supplies, poor supervision of staffs, and also poor organizational factors. Next. Yeah, so as we can see from the diagram, there are a lot of factors or issues that contribute to surgical patient good surgical outcome. And such as there are patient factors, we know patient, system, anesthesia, surgery. So all these factors together will help improving surgical outcome. So surgical outcomes depends on these factors. When you talk of patient factors, again, comorbidities, so pre-existing medical conditions that this patient has, and that may complicate during anesthesia management, or maybe an emergency condition or difficult airway, that is a patient factor. But when we also say system factors, that means lack of equipment, again, essential supplies, unavailability of tools and medications may hinder the good surgical outcome. And also anesthesia, as we know, the knowledge and skills, the availability of medication, and also surgery. So the complexity of the surgery, the skills of the surgeons may also impact or determine the surgical outcome. So in order or addressing all these factors requires a comprehensive strategy that together may result into a good surgical outcome. Next. Yeah, so that's where we're going to discuss on the Swiss cheese model. So the Swiss cheese model, this was a model that is also known as the Swiss cheese model of accident causation. So this one was developed by James Reason in 1990. And it is a theoretical framework that was used to illustrate how various factors that we have mentioned contribute to an accident or errors. Next. Yes, so as we can see from the diagram, that is the Swiss cheese model. The first thing that we are going to look at are the slices. As we can see, the 4 yellow slices. So the slices of Swiss cheese, each slice represents a defensive barrier or a safety measure that are designed to prevent an accident. But the holes, and we can see there are holes in the slices. So each hole represents a weakness within each barrier. So they are human element, their technical management and governance. That are the slices and also the defenses. But then there are holes within each of these components that are the weakness with each barrier. So, and then we can see there is accidental pathway. So when these holes come together and aligns, as we can see from the bottom, align it creates an accidental pathway. So this allow an error or hazard to pass directly through it and cause an accident. So all this work, as the Swiss cheese that mentioned how, or a theoretical mentioning on how an accident may happen, or how are we going to cover these holes to make sure that we do not create an accident pathway to make an error or an accident. Next. Yeah, so the slices, as mentioned, they are physical barriers, the administrative controls, so policies, procedures, the alarms, automation of the technology, but also on the human factors, as we saw one of the slices of the human factors. So training, experience, the skills, knowledge, those are the barriers. But the holes could be inadequate training or insufficient maintenance, poor communication, the technical failures, and also human errors. So when these holes again aligns, an accident pathway is created, allowing an error to occur. Next. Yeah, so when we identify the holes in the Swiss cheese, the slices and the holes, that is when we are going to think on how are we going to do on implementation on the Swiss cheese model. So one is to identify the potential hazards. That is to conduct risk assessment and evaluate potential risk in the process or procedures, which will help us anticipate a weakness and maybe manage it early, analyze incident reports. So identifying recurring issues and gaps in the system, and also solicit employee feedback. And again, implementation of the multiple layers of defense. So administration controls, policies, procedures, technological control, and also human factors. Next. So conducting of regular audits to perform systemic reviews or process to ensure standard safety standards, to also perform risk assessments, to evaluate the risk, to keep safety measures up to date for standards, and effective, to update procedures and training based on the updated or new insights and changes in the environment, to encourage to all foster open communication, encourage reporting near misses, and recognize and reward safe behavior. Next. Yeah, so that was all about the definitions, the introduction, and also the Swiss cheese model, as we have seen from the presentation. I would like again, thank you. I would like to again welcome Dr. Papicho to welcome our next presenter.
Thank you very much, Dr. Atala, for that nice discussion that you took us through. Now I'll call upon Dr. Mehmet Samuel. You can continue the discussion. You're welcome, Dr. Samuel.
Thank you, Dr. Papicho. I hope you can all hear me well. And also thank you, Dr. Atala, for your nice presentation. So I'd like to continue. Next. So starting with the case that was done in Nepal. So it was a descriptive cross-sectional study about critical incidents during anesthesia and early post-anesthetic period. The study found that critical incidents occur even in low-risk patients during anesthesia delivery. Yeah, so there are no simple cases in anesthesia and surgery. Also, patient factors and emergent surgery contribute to the most serious incidents. Next. So, crisis as a problem, as an abnormal situation that requires the attention of the anesthesia profession, but is unlikely by itself to harm the patient. So problems can then evolve, and if not detected and corrected, may lead to an adverse outcome for the patient. So a crisis is often perceived as sudden in onset and rapid in development, but retrospect, one can usually identify an evolution of the crisis from underlying triggering events. And so a critical incident is an incident that can directly cause an adverse patient outcome. So according to Cooper and colleagues, defined crisis as a human error or equipment failure that could have led, and if not discovered or corrected in time, or did lead to an undesirable outcome ranging from length of hospital stay to death. Next. Next. So how do problems evolve into adverse outcomes? Yeah, as you can see, we have latent errors. That errors are always there, and predisposing factors. We also have psychological precursors that eventually could lead to problems that often results from latent underlying conditions. And the triggering events could be the patient, could be the surgery, the anesthesia, and the equipment. Next. So prevention of problems, we have an example of the vortex where we had different lifelines, manipulations, adjuncts, size, type, suction, and muscle tone, with some instructions that it's safer to have a maximum 3 attempts at each lifeline, and at least 1 attempt should be by most experienced clinician. And also, we have another strategies that we normally use in our theaters, surgical safety checklist. We have the WHO surgical safety checklist that each institute and countries adapt from it and create their own checklist accordingly. Next. So reducing or eliminating the latent factors that predispose patients to problems would be the most effective strategy to improve safety. So it involves identifying and changing the organizational structure, work procedures, safety culture in our health systems. So these ways they are the results of complex evolution of medical practice and economics in combination with historical and political factors. But then external circumstances that cannot be controlled, even in these principles, are out of our control. For example, trauma, disasters, or patients with body trauma. We can't prevent problems such as that. Next. So despite attempts to prevent the occurrence of problems during anesthesia, experience shows that problems of varying severity occur in a large percentage of cases. Now, the exact frequency of problems is not known. Existing studies probably may have underestimated the occurrence of problems because they normally depended on written reports of the cases by the anesthesia professionals rather than the real-time experience. Now, in a study, out of observed 34,926 defined outcomes in the 17,201 patients, some experienced more than one outcome. You can find the study reference down there. 86% of patients faced at least one undesirable outcome. And they occurred in 18% of patients, either in the operating room or in the PACU. And 3% of all cases involved a serious event. Next. Okay, so we have a Brumley case, Human Factors in the Clinical Environment by Eve Laws. I hope we all love some movies. Maybe we can watch. Dr. Papicho can help us with that.
Just a routine operation. The Bromley case. Human factors in the clinical environment. On the 29th of March 2005, 37-year-old Elaine was due to undergo routine sinus surgery. The clinical team consisted of a highly experienced ENT surgeon, a highly experienced consultant anaesthetist and an assistant anaesthetist, a consultant anaesthetist from an adjoining theatre, and at least 3 nurses. The level of staffing and the skill set amongst staff was above the average NHS hospital. Modern equipment was readily available, including equipment for difficult airways. A thorough preoperative assessment was undertaken before surgery. At 8:30 a.m, Elaine was taken into surgery. Prior to surgery, Elaine's oxygen level was at 98%. Elaine was anaesthetized by the consultant and assistant anaesthetist. The time was 8:35. A laryngeal mask was to be used, but Elaine's muscles were too tight. Drugs to relieve the tension were administered, but to no effect. By 8:37, Elaine's oxygen level had dropped to 75% and she was turning
Now
visibly
things have
blue.
changed.
By 8:39, her oxygen level had dropped to 40% or lower. Tracheal intubation was attempted by the anaesthetists. Between 8:41 to 8:43, all staff had joined the team to help with the intubation. One of the nurses informed the surgeon and the anaesthetists that a bed had been made available in intensive care. However, the nurse received a look as if to say, "You are overreacting." The nurse phoned to cancel the bed. Another nurse fetched a tracheostomy kit, but its availability was ignored. By 8:45, it had become an emergency can't intubate, can't ventilate situation. By 9 AM, a laryngeal mask was eventually inserted, but it was unsecure. Elaine's oxygen level had risen to 90%. From 9:03, insertion of a tracheal tube was attempted, but was unsuccessful. Elaine's oxygen level had dropped to 49%. At 9:10 AM, the operation was abandoned. Elaine's oxygen level had been at 40% or lower for over 20 minutes. Elaine remained in intensive care until April 11th, when sadly she passed away. This emergency situation could have been handled differently. Identify the relevant work system factors that contributed to the management of the Bromley case at the time.
Well, thank you for the nice video. As we have all seen, the theater, all the staffing were there, the consultant, and the level of staffing is probably even higher, more than most of our health facilities, yeah? But you can see how human factors was involved in such a case, and wrong decisions were made, and the problem that led to an incident crisis. Yeah, so we have all seen that if the measures were taken correctly and timely, probably the patient could have survived, and because the patient had an increased length of hospital stay and eventually died. So we have seen from the Bromley case how human factors in the clinical environment could lead to such incident and lead to problems to a patient. Next. So anesthetist non-technical skills system is a behavior marker system developed by industrial psychologists and anesthetists during a 4-year collaborative research project in Scotland. So it used integrally with medical knowledge, clinical skills, non-technical skills should help to support safe and effective performance in everyday tasks and emergency situations. It also describes the main observable non-technical skills associated with good anesthetic practice. So it includes team working, where in teamwork we can coordinate activities with team, assessing capabilities, supporting others. Also, it includes task management, which includes planning and preparing, prioritizing, and also situation awareness, where we gather information and we anticipate for the problems before they do occur. It also includes decision making, where we can identify options, balancing risks, and selecting options and reevaluating. Next. So the importance of non-technical skills to the anesthesiologist. 80% of all errors in medicine can be attributed to the human errors and awareness of non-technical skills. Human factors are the study of environmental, technical, organizational, psychological, and physiological influences on human performance. In the National Audit Project 5, in the 5th National Audit Project, which reviewed accidental awareness during general anesthesia, 73% of incidences of awareness and anesthesia were reported due to miscommunication. Now, the importance of anesthetist non-technical skills in reducing medical errors related to human factors has been recently recognized. Next. General recommendations involves training, which may take some time for users to become familiar with the anesthetics non-technical skill system. Also, teaching and assessment should not interfere with clinical care. And also formative assessments and feedback on anesthetist non-technical skills should occur routinely in both clinical and simulated environments. Next. So we have something called the Anesthesia Incident Reporting System. Now, we cannot change the past, we can only take action in the present and therefore change the future. And also we can't fix what we can't detect. So please consider reporting events at the link below at akias.org. Ultimately, our patients are the beneficiary of this work. Next. So what is ARS? Anesthesia Incident Reporting System. It was created specifically to detect rare and novel adverse events that occur in national healthcare systems in the perioperative period. Involves equipment malfunctions, medication errors, rare complications. All this can be reported in the system. Now, the incident reporting system is designed to improve patient safety by identifying hazards for improvement. Over the years, thousands of detailed event reports and tens of thousands of cases of harm have been submitted associating with anesthetic complication. Incident reporting began locally in the 1930s. First case of anesthesia critical incident reporting in 1954. Now it expanded over time to cases of patient harm and cases where patients were almost harmed. We call it near miss by an unsafe condition. Next. So the WHO promotes reporting and encourages healthcare organizations to create a culture that supports and encourages this in a confidential, non-punitive approach, which you have been struggling in many of our different countries. Because such reporting system have created such blame environment conditions, and people become afraid to report such scenarios or such incidents. Now, reporting systems are required to be easily accessible to everyone, user-friendly, and very anonymous. They can be electronic or paper-based, but need to facilitate timely reporting and analysis of incidents. Now, reporting itself does not lead to changes. So reporting needs to occur, but also analysis needs to occur for the incidents. So it involves information where details of the event, such as patient demographics, anesthetic provider, surgical procedure, daytime, location, and etc., everything should be included. Investigating reported incidents to determine the underlying causes and contributing elements is very essential. It's like analyzing the reported incidents. We also need, WHO also recommends transparent communication regarding incident reporting, and its outcomes will further support a culture of reporting and patient safety. So it needs to be adapted and implemented according to each healthcare organization's specific context and needs. Next. So these are the common elements of incident reporting system. It has to involve confidentiality, non-punitive strategy with no blaming each other, have reporting mechanisms, analysis and investigations, feedback and learning, and also an incident reporting form. Now, what are the differences between high income countries and low middle income countries? So 2010, nearly 1/3 of global deaths were caused by conditions requiring surgical care. By 2015, by the Lancet Commission on Global Surgery, emphasized the importance of universal access to safe and affordable surgical and anesthetic care. Perioperative mortality reflects surgical and anesthetic safety, while global perioperative mortality rates have decreased over the past 50 years. Low middle income countries still face a 2 to 4 times higher risk. Improving anesthesia services has been identified as a priority in a global health. Anesthetic providers training backgrounds, especially in low middle income countries, and shortage of physician anesthesia providers have been the shortcomings and the limitations in improving this. In countries with advanced resources, anesthesia incidence reporting systems are commonly more established and comprehensive. Yeah. Some key differences include infrastructure, availability of technology, reporting culture or reporting behavior, training and education, and outcome data analysis and feedback mechanisms. These are the key differences between the high-income countries and low-middle-income countries. Next. So in a study done in USA about the anesthesia and perioperative incident reporting system, showed that the incident reporting system, IRS, continued to be an important influence on improving patient safety. IRS can provide valuable insights into how to prevent patients from being harmed at the organization level. Healthcare organizations need to develop effective strategies built on trust and truth-telling to improve the impact of IRS. Training data analysts to focus on the system instead of the individual through a balanced, simple taxonomy. Also combine the analysis at the local level to reinforce effective and personalized feedback with the potential of a national or supranational learning platform. Next. So strategies to improve worldwide anesthesia incident reporting. Develop and implement a standardized anonymous reporting system worldwide. Encourage all healthcare facilities to regularly audit and verify the reporting of incidents and assess the efficiency of the reporting system. Advocate and create cultures of safety in clinical practices where people can actually learn and be used to reporting such incidents. Encourage the use of feedback mechanisms in healthcare facilities. Establish collaborative efforts among diverse nations and healthcare institutions. It can also facilitate exchange of exemplary methodologies between the institutions. Also utilize technologies such as mobile applications, web-based platforms. Now we have also AIs. Also pursue legal safeguards for all the healthcare professionals who disclose critical incidents. Not only legal, I would recommend also psychological care. Next. So what should we go home with? Anesthesia-related death are in most cases preventable and avoidable. Anesthesia-related complications are underreported. Reporting systems are required to be easily accessible, non-punitive, and de-identified. Healthcare organizations to create a culture that supports and encourages this in a confidential, non-punitive approach. Thank you. Back to you, Dr.
Thank you very much, Dr. Samuel, for this nice discussion. The floor is open for question or comment. If you don't want to unmute yourself and speak. Marian, do you have an option to unmute?
Yes, if you just raise your hand, I can unmute you. It looks like one person is unmuted at this point.
Thank you very much. So you can raise your hand and then Mariam will unmute you and then give you an opportunity to ask a question. Or either you can type your question in the Q&A and then the panelists will look at it and answer it.
Can I proceed? Hello.
Yes, go
Yes,
ahead.
please. Go ahead.
Yes, this is Eric from Kenya, Homa Bay County, concerning the total spinal and high spinal that attributes to around 6% of mortality, maternal mortality in Tanzania that has been posted by a friend. What are the commonest issues that happen? Is it human error or patient-related factors or drugs? Because I would also wish to know the kind of bupivacaine that is being used in Tanzania, is it majorly the isobaric or hyperbaric type? Because it is also a challenge in some of our facilities here in Kenya. Thank you.
Thank you very much, Eric. Shetan, are you there? Or someone who's got data related to the question? Dr. Sweetbert, can you come along?
Yeah, thank you. I am one of the steering committee members of the MPDSR, where we do routine audit of maternal deaths, and for the last 3 years. And what we have learned is that women who are short, who have got a macrosomic fetus, multiple pregnancy, and from the physiological events which occur during pregnancy, the neuroaxial space is reduced. So routinely, the training which they get is you give 10 milligram of the high hyperbaric bupivacaine. So the recommendation in our audit, the action plan is that we reduce the dose from 10 to 7.5, and then be very aware of the dermatome level where you are, and then catch the patient early if there is any ascending features, example vomiting and then nausea and such things. Because what happens sometimes that the anesthetist, after giving the dose, you just disappear outside the theater, relax, and patients will continue, the surgeon will continue, and so forth. So I think human error as well as technical error may be responsible for all these catastrophes. And regarding tranexamic acid accidents, the vials of tranexamic acid and the bupivacaine, they are very similar. So we're trying to recommend the purchaser from the government to try and look for alternative ampules where you can be able to differentiate between the two ampules. We had such catastrophes, and it is very sad. Thank you. I submit.
Thank you very much for that comment. I'm not sure if Eric would like to bounce back on it, or you're okay with that?
I'm okay with that. Thank you.
Okay. There's a chart that I would ask Mariam to share on the chart that can be used for dose of bupivacaine related to the height and weight of patient. Maybe can also be used for reference. It's a chart that was discussed some few weeks ago on the Global Anesthesia Society. Mariam, could you please share that chart that I've shared with you in the chat on the webinar, so that it can help our colleagues to look at it and use it as reference when it comes to dosage?
Sure, I'll share it now. I'm just going to stop sharing my screen, but feel free to go on with the questions while I do that.
Sure, thanks. Okay, any other question or comment? Okay.
Mr. Chairman, I would like to add one note that in the most CPOC centers, we have gathered data that some of the nurse anesthetists, they have not done intubation for almost 5 years. So they continue to give spinal, and then once there is a challenge of introducing the ETT, it becomes a challenge. And when they do it, the most common anesthesia given if they have to convert is ketamine. There is no balanced anesthesia drugs available, no this Drager machine or universal anesthesia machine, even if there is, they may not be having skills to operate it. So all these things contribute to the problems. Thank you.
Thank you very much, Mariam, for sharing it. Yeah.
Thank you, Dr. Papicho.
Yes, please.
I would like to add on what my fellow comrade commented. Yeah, the causes, the human factors, currently in our country, in Tanzania, we have a huge gap in knowledge, in clinical knowledge, and human factors contribute a lot in total spinal and high spinal. Yeah, you can find lack of vigilance. Most anesthetists, yeah, they can offer spinal anesthesia if they won't monitor the patient. Also, there's a lack of clinical knowledge. Most anesthetists have strayed away from intubating and managing airway. Yeah, but what the government is doing is the government has offered mentorship programs where surgeons, anesthetists, specialists all over the world, all over the country, rotate in different regions, different healthcare facilities, where we go there, we train anesthetists, we train surgeons, we train medical doctors, and we remind them on how to offer safe anesthesia and safe science. So this is one of the interventions that our government have done so far, and it continues to do it over the years. Thank you.
Thank you very much for that contribution, putting more clarity on the pending matter on the floor. Yeah. Any other hands? Okay, there's a request from Clinton. Clinton, this webinar and all the documentation will be shared on the Guardian website, so everyone can get access to them. The record, the PowerPoint presentation, everything will be available. At any time, you can go on the website and get all the information. If there's no any other question,
Hello, Papito.
Please.
Yeah, I just wanted to quickly jump in also. Thank you so much, first of all, for the great discussion so far. Dr. Ndaba from Zambia. Yeah, I just wanted to add and also just to emphasize on the mention of the non-technical skills as being key in the prevention of anesthesia-related critical incidences. We learned from I think the first presenter clearly mentioned that generally, compared to a few years back, mortality directly due to anesthesia has sort of shown some declining trend because of advancements in the field of anesthesia. We have monitoring, we had so many devices, airway, and other rescue equipment to avoid critical incidents. So with that development in anesthesia now, I think it now borders on human behavior, which constitutes the non-technical skills like communication, planning, teamwork, leadership, and all of those things to actually help us to prevent unnecessary mortalities. Because really, truthfully speaking, most of the critical incidences that we experience, most of them are actually preventable and avoidable. Human error there is becoming key. Sometimes we don't pay attention, sometimes we don't prepare well, and sometimes we don't assess patients, you know. So it's all centered on human behavior and also attitudes. Like I think one of the previous contributors mentioned that even just for spinal anesthesia, I think generally we tend to relax, thinking that spinal anesthesia is safe. So you forget to prepare your drugs, emergency drugs, no airway equipment, you know, nothing. And then when you have a severe hypotension, you are unable to resuscitate. So clearly there, it's just human element at play. So I think I like the fact that this presentation has brought out key messages on the non-technical skills and how they relate to our performance and also avoiding critical incidents. I think that message should need to come out very strong. We need to deal with the attitude within the practice. We need to go back to the basics and respect the profession the way it is, because anesthesia really is a very delicate practice. It's a very delicate profession, and we need to respect it the way it is. So I think non-technical skills are becoming more and more important to talk about in this era or generation where generally there's an improvement in some of the things that used to be a challenge years back, such as monitoring, you know, lack of adequate airway equipment. Now we may seem to have access to some of those things. So what is there now is just the non-technical skills, attitudes to deal with. And I think we can significantly reduce anesthesia-related mortalities to zero if only we sort of harnessed and put together the non-technical skills, which have been well and clearly described in the presentation. So great presentation, great discussion so far. Thank you so much. I just wanted to highlight that, the moderator. Thank you.
Thank you very much, Dr. Ndaba. I'm not sure if Dr. Sweetbait also have some closing remarks.
Thank you very much, Dr. Tala, Dr. Maynard, and was chairman. And actually, thank you very much, Dr. Chetan, my senior, for the experience of shared. Basically, I quite agree with the difference we have in Tanzania, of course, with experience. But what we need the training, and we need mentorship. And of course, we need to create a system, maybe protocols, and basically not only create protocols, but also making sure we respect them and we work well with them. And that's the only way we'll try to take out the non-technical skills. And then for the skills, that's a little bit different, but I can assure you, with a proper system whereby the non-technical skills are well taken care of, where people they are responsible, people they know that they are giving right drug with the light load, with the proper and good communication, preparation, making sure you have an assistant, but not one assistant, qualified assistant with a skill. Of course, now and then doing simulations for the rare event, for those who are nearby simulation centers. I think that's the only way we will improve our anesthesia safety. But I think it's upon everyone in theater, as for example, the chat we have shared. Most of these things, they are online, whereby you can just look for it, print it, and put it somewhere where you can access easily. I think my take-home message will be all anesthesia provider theater team, let us be responsible and let us look for one another, and then our patient will be very, very safe. Once again, thank you for organizing this wonderful presentation, which actually has shown us where our weaknesses are, and then I think it's time now we should pull up our socks, go back to basic, and make sure we provide the safe anesthesia and safe surgeries. Thank you very much.
Thank you very much, Dr. Sweetbird. Now I'll call upon Mr. Ngajima, if you can come up for closing the webinar.
Okay, thank you so much, Papa. But before we go that, I saw hands for a long time. So are we allowed them to go on, or what do you think?
If there's a hand, we can still give him a chance. We hear from him.
Yes, I think there is somebody called the Clinton and the Tafa. I think they can go on before
Okay, please.
Yeah.
We can be unmute so that we hear their comments. Thank you for
Good afternoon, everyone. Am I being heard clearly?
You are clear. Please go ahead.
Okay, thank you. Thank you for the presentation and the discussion so far. I'm Dr. Sunlaja Tavaluakayode. I'm an anesthesiologist practicing in Lagos, Nigeria, in the West Africa. I once conducted a research on anesthesia-related death, and I found out that I want to share my experience or my findings. Just like it is presented in the case cited, the commonest cause of anesthesia-related death that I found out was respiratory. Therefore, when we are conducting anesthesia, pre-op assessment is very, very key, and there must be adequate planning for whatever the procedure we are going to embark upon. And we should have plan A, plan B, and possibly plan C. I found out that at the same time that most of the time it occurs during emergency, during call hours where the specialists or the consultants were not on ground to adequately monitor the junior ones that are on duty. And just like is suggested, when we are conducting our anesthesia, we should have the ability to be able to listen for just suggestion and consider the suggestion that are being offered to us, so that if it's a good suggestion, no matter who is making the suggestion, we should actually take to it. Thank you very much. I actually enjoyed myself this afternoon. Thank you.
Thank you, Doctor, for the nice contribution. That is experience talking now. Thank you very much, Doctor. Ngajima, there's another hand on my side. I can't see much.
Tafa, is it Tafa? Tafa, the one who is talking shortly?
No, I'm done.
You're
Okay,
done.
sure.
Okay. Thank you so much. Anton, can you move?
Yes, Anthony.
Anton,
Yes. My question was concerning do we have a standardized incidence reporting format for all countries in Africa, or are we adopting the American or the European? Because I've seen a lot of incidence reporting format is different from different regions of the world. So are we having a standardized incidence reporting format? Thank you.
Dr. Sweetbird, can you pick up that question?
Thank you, Anton. I think that is the straight answer is no, I have to be honest. But I think it's time now we have to, that's why I think it's one of our recommendations that organization, they should now adapt and have that system, because as we said, you cannot learn, you cannot change the past, but you can learn from the past and get to the new future. I think it's time now, the way we did it, the ASOS study, that is me talking now. I think the way we did the ASOS study, whereby country contributed, I think we needed the African incident report.
Yes.
So countries should go, we can start it, every country can start its own, but I think the easiest way, we need a African incidence report, whereby we understand that we have our own problem.
Our
we
own
have
problems,
our
our
own
own challenges, yes.
We have everything which we are unique. So we cannot compare ourselves with the other guys. So I would suggest if we have to take it from here, it's upon us to come together and come up with our own incident report for Africa. That's the only way we resolve our problem, and that's the only way we move on. Thank you.
Yes, thank you.
Thank you very much, Anthony. Thank you very much, Dr. Sweetbird. Mr. Ngajima, have you cleared everyone, or there's another hand?
Yeah, we are clear. Don't see it.
Okay, thank you very much. Your floor is yours, sir.
Okay. Okay, thank you so much, Papicho, for your time, and thank you so much to our presenter, Dr. Tala and Maynard, plus the panelists for having with you this evening, as far as all the participants for your vital time to participate on this session. So as a guardian, we thank you so much for your time and for dedicating your time to be joined with us and having or learning together in this evening. So by saying this, I wish you having a good evening, all of you, for those who ending their day, and have a good morning for those who starting their day. Thank you, guys.
Thank you.